You're pregnant. You're in a car accident. You need an X-ray. Should you panic? For decades, doctors followed a rule designed to protect unborn babies from radiation. There was just one problem. The rule was backwards. It actually increased the risk it was meant to prevent. This is the story of how we got radiation and pregnancy wrong, what the science actually says, and why understanding this matters for every medical decision you'll ever make. Starting in the late 1950s and 1960s, medical authorities introduced the 10-day rule. It stated that women of reproductive age should only get X-rays of their abdomen or pelvis during the first 10 days after their period starts. The logic seemed solid. If you only X-ray women early in their cycle, you'll never accidentally radiate an embryo, because conception hasn't happened yet. Doctors implemented it worldwide. Countless X-ray appointments were rescheduled. Women waited weeks for crucial diagnoses. But there was a fatal flaw in the reasoning. Those first 10 safe days ended right before ovulation, when a woman's egg is maturing and preparing for release. Eggs in this pre-ovulation phase are incredibly vulnerable to radiation damage. If you irradiate an egg just before conception, you might damage the genetic material that will become half of a future human. The rule designed to protect embryos was instead exposing eggs at their most vulnerable moment. By 1984, scientists realized the mistake. The 10-day rule was quietly abandoned in most places, replaced by simply asking women if they might be pregnant. But this embarrassing reversal revealed something important. Radiation and pregnancy is not simple. The danger depends entirely on timing, dose, and a brutal principle called all or nothing. Here's what actually happens when an embryo gets irradiated in the first 3 weeks after conception, before it implants in the uterus. Nothing, or everything. At this stage, the embryo is just a handful of cells, maybe a couple hundred at most. None of them are specialized yet. Every cell has the potential to become any part of the body. If radiation kills a few cells, no problem. The remaining cells compensate and develop normally. The embryo survives completely unharmed, but if radiation kills too many cells, and it doesn't take much, possibly as little as 100 milligray, the embryo can't recover. It dies and is naturally miscarried, often before the woman even knows she's pregnant. This is the all-or-nothing principle. Either the embryo survives intact, or it doesn't survive at all. There is no middle ground, no birth defects, no lasting damage. Just binary, life or death. This happens because, at this early stage, losing even a small percentage of cells means losing a significant chunk of a future organ system. The embryo is too small and undifferentiated to work around the damage. Ironically, this makes the pre-implantation period one of the safest times for accidental radiation exposure. If the embryo survives, it's fine. The problem is about 1 in 3 to 1 in 10 pregnancies naturally end during this window anyway, so if a miscarriage happens, it's impossible to know if radiation caused it, or if it would have happened regardless. The real danger comes later. Once the embryo implants and begins forming organs, everything changes. Between weeks 3 and 8 after conception, the embryo undergoes organogenesis, the brutal, precise process of turning a blob of cells into something recognizably human. Heart, brain, spine, limbs, eyes, everything forms during this narrow window. Radiation during organogenesis can cause malformations. Not death, but developmental abnormalities that the child will carry for life. But even here, dose matters enormously. The threshold for causing detectable birth defects is somewhere around 100 to 200 milligray. Most diagnostic X-rays deliver far less than that. The most sensitive window of all is weeks 8 to 15 after conception, when the brain's cortex is forming. During this period, radiation above 100 milligray can measurably reduce IQ. At doses around 1000 mg, 1 gray, there's a high probability of severe intellectual disability. The brain is building itself neuron by neuron during these weeks, and radiation disrupts the process in ways that can't be repaired later. After week 16, the brain becomes progressively more resistant. By the third trimester, the fetus is much less vulnerable to radiation effects on development, though cancer risk remains throughout pregnancy. So how much radiation are we actually talking about? Here's where the fear often doesn't match the facts. A chest X-ray delivers about 0.01 milligray to a fetus. That's essentially nothing. You could have 100 chest X-rays during pregnancy and still be nowhere near the threshold for harm. An X-ray of your arm, leg, or skull. Also negligible. The fetus isn't even in the radiation beam, and what little scattered radiation reaches it is trivial. Even an abdominal X-ray typically delivers only 1 to 4 milligray. An X-ray of the pelvis, about 1 milligray. A lumbar spine X-ray, maybe 2 milligray. These are all well below the levels that cause concern. But then there are the high-dose procedures. A CT scan of the abdomen can deliver 8 to 50 milligray to a fetus. A CT of the pelvis can reach 25 to 80 milligray. A barium enema, 7 to 24 milligray. These procedures start approaching or exceeding the 10 milligray threshold, where doctors get cautious. They're still usually below the 100 milligray level, where developmental effects become likely. But they're in the range where careful consideration is needed. Multiple CT scans, or certain fluoroscopy procedures that run for extended periods, can push doses even higher. This is why the modern approach isn't a blanket rule, it's a calculation. How much radiation? At what stage of pregnancy? And crucially, what's the alternative? Here's the brutal truth. Sometimes not doing an X-ray is more dangerous than doing it. A pregnant woman in a serious car accident might have internal bleeding. A CT scan could save her life and her baby's life. The radiation risk is real, but it's small compared to the risk of dying from an undiagnosed injury. A pregnant woman with severe abdominal pain might have appendicitis. Delaying diagnosis could lead to a ruptured appendix, sepsis, and death. An abdominal CT delivers radiation, yes, but it also prevents catastrophe. According to international radiation protection guidelines, termination of pregnancy is not justified at fetal doses below 100 milligray. Between 100 and 500 milligray, the decision depends on individual circumstances, ethical considerations, and patient counseling. Even at doses above 500 milligray, where significant harm is possible, the decision is complex and deeply personal. Medical radiation exposure during pregnancy is never taken lightly, but it's also not an automatic disaster. Every case is evaluated on its own merits: the dose, the timing, the reason for the exam, and what happens if you don't do it. There's another group who worries about radiation and pregnancy: the people who work with it every day. Radiologists, radiology technicians, interventional cardiologists, nuclear medicine staff. These professionals are occupationally exposed to radiation. What happens when they become pregnant? International guidelines recommend keeping fetal dose below 1 milligray during a declared pregnancy for healthcare workers. Here's the surprising part. This is usually easy to achieve. The lead aprons that radiology workers wear are incredibly effective. If a pregnant technician wears her dosimeter badge outside her lead apron, as is standard, the badge might measure 10 milligray over several months. But the fetal dose, about 0.1 milligray, 100 times less. Even workers who don't wear lead aprons, like those in nuclear medicine, typically deliver fetal doses well below the 1 milligray limit with normal precautions. Some pregnant workers choose to transfer to lower exposure areas, like moving from fluoroscopy to CT scanning, or avoiding certain procedures. Others continue their regular duties with careful monitoring. The key is measurement and transparency. A healthcare worker who declares her pregnancy early allows her employer to assess her typical exposure and make informed decisions. It's a reminder that radiation protection isn't about eliminating all exposure. It's about understanding dose, managing risk, and making rational choices. Radiation in pregnancy is not a simple story of danger and avoidance. It's a story of thresholds, timing, and trade-offs. Most X-rays during pregnancy deliver doses so low that they pose essentially no risk. A handful of procedures deliver doses that require consideration but are often still justified. And in truly rare cases, high doses require careful counseling and individualized decisions. The all-or-nothing principle protects embryos in the earliest weeks. Specific windows of vulnerability exist for organ formation and brain development. But even during these windows, the dose has to reach a certain level before harm occurs. And perhaps most importantly, fear of radiation shouldn't prevent necessary medical care. Doctors have spent decades refining guidelines, measuring doses, and balancing risks. The modern approach is far more sophisticated than the blunt instrument of the 10-day rule. If you're pregnant and need an X-ray, here's what actually matters. Ask about the dose. Ask about the timing. Ask about alternatives. And ask about the consequences of not doing it. Because sometimes the most dangerous thing you can do is nothing at all. If you found this video helpful, consider subscribing. This is our first video, and we're building a channel dedicated to taking complex medical and scientific topics and making them clear, accurate, and engaging. Hit that like button if this changed how you think about radiation and pregnancy, and drop a comment if there's a medical image-related topic you'd like us to cover next. Thanks for watching. We'll see you in the next one.